Welcome to my educational video of oral anti-diabetic medications for primary care nurse practitioners and nurse practitioner students. I'm Jibi, currently working as an autonomous nurse practitioner in Right Focus Healthcare LLC. As we know, the diabetes drug market was estimated 84 billion in 2024, is going to increase it to 137 billion by 2030. So, with this increased cost of diabetic medications and the availability of different type of medications, as we see in the media in the last 5 to 7 years, there are names with sound alike, look alike. So, the goal of my video is to educate nurse practitioners and make them experts in prescribing these different type of medications to different type of patients based on their medical conditions, their living situation, and how much they can afford. So, first we will do a knowledge assessment quiz of oral anti-diabetic medications, and then there will be a discussion of overview of pathophysiology of type 2 diabetes and the diagnostic criteria. Then I'm going to discuss different classes of anti-diabetic medications. According to National Institute of Health, there are 10 classes of oral anti-diabetic medications. In this video, I'm going to discuss mainly 6 of them, which include Biguanides, Sulfonylureas, GLP1 receptor agonist, SGLT2 inhibitors, DPP4 inhibitors, and Thiazolidinedions. Their mode of actions, which class of medications they belong, their side effects, and what we have to be cautioned prior prescribing them. And then there is quiz answers. So go ahead in the next slide, try to answer this quiz of oral anti-diabetic medications. Quiz oral diabetic medications. Which class of diabetic medications is not a choice if patient has hypoglycemic risk? A. Sulfonylureas, B. SGLT2 inhibitors, C. TCDs, D. DPP4 inhibitors. Which medications has higher risk for a lower limb amputation? A. Canagliflozin, B. Empagliflozin, C. Pioglitazone, D. Metformin. Which class of medication should be avoided in medullary thyroid cancer? A. TCDs, B. DPP4 inhibitors, C. Sulfonylureas, D. GLP1RA. TCDs, the expansion is thiazolidinedions. Please watch my video. You will be able to answer the quiz. Let us start the video with a discussion of the pathophysiology of type 2 diabetes. It's a metabolic disorder characterized by chronic hyperglycemia due to two main factors. Number one, insulin resistance, and number two, beta cell dysfunction. So, in this normal human body, the insulin promotes glucose uptake to cells. In type 2 diabetes, the body cells, especially in muscles and liver and adipose tissue, the insulin receptors lost their sensitivity and they become less responsive to cells, become less responsive to insulin. So the glucose cannot penetrate the cells. So there is less uptake of the glucose, but liver continue to produce glucose despite this high blood glucose, and there is no activity in the cells. That will lead to hyperglycemia. But early in disease, the pancreatic beta cells responds or compensate by producing more insulin. So then that keeps the blood glucose level normal. That is called a pre-diabetes. But over time, this beta cell become dysfunction and the cells cannot produce insulin. So the insulin production declines and the insulin deficiency contribute to persistent hyperglycemia. This beta cell dysfunction may be due to autoimmune causes or genetic or environmental causes. Let's do a quick overview of how to diagnose type 2 diabetes and how to confirm it. As you see in the picture, the fasting blood glucose greater than or equal to 126 milligram per deciliter. Fasting is defined as no calorie intake for at least 8 hours. And then 100 to 125 is pre-diabetes. Pre-diabetes is a term used for individuals whose glucose level does not meet the criteria for diabetes but still have abnormal carbohydrate metabolism. We already discussed in the pathophysiology about it. And then normal is below 100. Then second one, 2-hour plasma glucose greater than or equal to 200 mg per deciliter. This is after a 75 oral glucose tolerance test. Then this is also 140 to 199 is pre-diabetic, and less than 140 is normal. Then number 3, HbA1c greater than or equal to 6.5 percentage. This should be done in a standardized laboratory. And then 5.7 to 6.4 percentage is pre-diabetic, and less than 5.7 percentage is normal. Then fourth criteria, random blood glucose greater than or equal to 200 milligram per deciliter with the symptoms of hyperglycemia. These symptoms include polyuria, polydipsia, which means increased thirst, and unexplained weight loss. So unless the patient present with the classic symptoms and the blood sugar level is high, this diagnosis of diabetes requires 2 abnormal screening test results, which should be measured either at the same time or at 2 different times. For example, if the patient comes with a fasting blood sugar greater than 200 or HbA1c greater than 6.5 percentage, we can diagnose at the same time. Or these 2 abnormal tests, a different test performed at 2 different times. But another thing, if only one test is higher, for example, a patient come to you and with HbA1c 6.8 percentage, and when the repeat test is 6.7 percentage, that is also we can confirm as type 2 diabetes. Next 2 slides, we will learn about how to correlate the names of the medications with the medication class. For the new nurse practitioners, I advise go with the generic names. So then as you see the patients, you will familiarize with the brand names. So the first one, the insulin sensitizer, as the name implies, it promotes insulin secretion. So we can remember this one doesn't have a competitor, so you can remember B as the best of all, because this is the first line of therapy, and then also unless until very much contraindicated, and also it's affordable. Next one is Thiazolidinedions. It's a pioglitazone or oxyglitazone. So how do you remember this? This ons as a suffix, and zone, glitazone is a group, and glitazone, rosiglitazone. So by the zone as a suffix, there is no other names with that, so you can remember like that. Next group is insulin secretagogues. As the name implies, it promotes the insulin secretion. So the group in that is sulfonylureas. This one is not that difficult, because for nurses, we are all familiar with the names, glimepiride or glimepiride in other accents, and glyburide, glipizide. So those are the medications in that group. Then meglitinides, repaglinide. So that one is the nides, glinides, so you can remember that. This one, the medications that we are not much using and rarely used, I'm not going to talk about further. The other medications I'm going to talk about it. So this one is rarely much used because it has the side effect of these insulin secretagogues. When the insulins are produced more, there is chance of hypoglycemia and weight gain, but not cheaper like sulfonylureas. They are from the dollar estimate $31 to $800 it can range. So it's expensive and it has a side effect. So that is rarely used. So next is incretin based therapy. As we know, that means it's using the incretin hormone principle in that. That is that we are going to talk about it further. Then it's a DPP4 inhibitor. The expansion is dipeptidyl peptidase. So the PT sound, you can remember that. So sitagliptin, PT, and linagliptin. So PT sound, so that there is no other ones, but there are similar sound alike drugs. So that is why you have to remember by DPP for the expansion, dipeptidyl peptidase. Is also about classification of diabetic medications. Just to familiarize the name with the class of the medication. So the first one is glucose excretion enhancers. Whenever the word excretion is there, it is regarding the renal system and the urine. So SGLT2 inhibitors is the group, and expansion is sodium glucose co-transporter 2 inhibitors. So how do you remember? It's flushing out the urine. So empagliflozin, flossing out, you can remember like that. And dapagliflozin, so flozin. There are similar kind of sounding names, but there is nothing like flozin, so you can remember by that. Next is carbohydrate absorption inhibitor. As the name implies, it delays the digestion and absorption of the carbohydrate in the intestine. So the class is alpha glucosidase inhibitor. The names of medications are acarbose and miglitol. You can remember by GI, either by GI. So there are GI symptoms involved, side effects. It's abdominal pain, bloating, flatulence, diarrhea, or you can remember A for abdominal pain and all that. And there is hypoglycemia if taken with other medications. They are cheaper, but it's not preferred medication because it's not recommended if the creatinine clearance is less than 25, and not much of a benefits like cardiac or even any other benefits of the other medications. So I won't be talking about those medications. Next is incretin mimetic. As the name implies, it mimics the incretin hormones. The GLP-1 receptor agonist is a group, and its expansion is glucagon like peptide 1. So how do you remember? The glue in the first and the tide in the last. So liraglutide, glutide, semaglutide, glue and tide. So these all names look similar, but if you remember the expansion of their class of medication, it won't be harder. How it's easier to use that when you're prescribing to the patients, you will remember the class of the medications and their side effects, so it would be the right prescription for the patient. Next one is amylin analog. This one also is rarely used and not preferred, so I won't be talking further about it. The other brand name is Simlin. They are expensive, like about $1,000, but compared to the money we are spending, it doesn't have much of the benefits. Benefits like cardiac or anything. It's only the benefit of weight loss, and there are side effects. It slows gastric emptying and suppresses postprandial glucagon release. So there is GI system, so you can remember by A again, by abdominal pain, nausea, vomiting, and loss of appetite, and A for allergic reactions, itching and all that. And then so this is not a preferred medication. The side effects plus expensive. And one point to remember, this pramlintide, so that you can remember by amlin. So amlin here. But it shouldn't be get confused with the rapaclinide, the meglinide group. That is glyinide. So you can differentiate between those two. That is a meglinide group, the rapaclinide. This is pramlintide. In the next slides, we are going to discuss about 6 major class of medications, their mechanism of action, and their advantages and disadvantages. Let us start with the metformin. As we already discussed, it's an insulin sensitizer, and it belongs to the class of biguanides, which you can remember by best of all, because there are a lot of advantages. They are inexpensive, which is $10 to $13 for a 30-day supply, and it works in their mechanism is reduces liver glucose production, and there is increased sensitivity in muscles for the insulin, and then there is delay absorption of glucose in the intestine. So there are 3 places the metformin is, as in liver, muscles, and the intestine. So that's a superior from the other drugs. And there is the advantages are effective A1C reduction 1 to 1.5%. That's also comparatively a little bit good and better. lower risk of hypoglycemia, weight neutral or modest weight loss, cardiovascular benefit, especially in overweight patients, inexpensive and widely available. And this is the first line therapy in type 2 diabetes unless until there is any major contraindications. Disadvantages, anytime there is a delay absorption of glucose in the intestine or GI system is involved, nausea, diarrhea, abdominal discomfort, and then can cause vitamin B12 deficiency with long-term use. So when the patients complain of numbness, make sure we are not thinking that is from the diabetes. So just make sure we check the vitamin B12 when they are on metformin. Then contraindicated in severe kidney disease, especially the GFR is less than 30 ml per minute. Then there is risk of lactic acidosis. It's a rare, but it's a serious one. So how do we diagnose lactic acidosis? The serum lactate level normally is less than 2 millimole per liter, and when it's going to be severe lactic acidosis when it is greater than 4 millimole per liter, and the ABG will be altered. The pH will be less than 7.35 and PCA2 will be less than 42. The major symptoms in the beginning was this diarrhea and decreased appetite, fast or shallow breathing, muscle pain or cramping, and unusual sleepiness. In severe cases, there will be altered mental status, hypothermia, hypotension. So how does this happen? The lactic acid produced in the body is metabolized by liver and kidney. So when the metformin is prescribed on patients with renal impairment or any acute illness, they have it, or dehydration or alcohol consumption, and then older individuals, because of the age, there is a decline in the kidney function, so they are at risk. Then we can discontinue the metformin and treat the underlying cause. And then that is why it's not suitable in patients with a kidney disease. The renal function is less than, GFR is less than 30, and then severe liver or heart failure. Why not in heart failure? Because when in heart failure, the blood flows to the, and the oxygen supply to the tissues are reduced, so there is more risk of lactic acidosis. But the recent study shows that the metformin can improve actually myocardial function and reduce oxidative stress, and there is improved outcome in the heart failure. But we have other choices of medications, so this choice of metformin in heart failure should be individualized. Next is about sulfonylureas. As you see, it belongs to the group insulin secretagogues, which stimulate insulin release from the pancreas. So what is the mechanism of action? It says closed potassium channels in beta cells leading to insulin release. So let's examine. The sulfonylurea is combining with the sulfonylurea receptor. So that leads to the blockage of the potassium ATP channel. When they are blocked, there is depolarization of the membrane that causes the calcium channel to open up, and then there is influx of the calcium that causes increase in intracellular calcium, and that causes the release of insulin. So what are the names of the medications? Glimepiride and glyburide and glipizide. So glimepiride is the dose is 1 to 2 milligram per day. You can start at that dose, and there is up to 4 milligram availability of medications is there. And then glyburide, the starting dose is 2.5 to 5 milligram. Glipizide is 5 milligram per day. You can start at 5 milligram per day, and then maximum is 40 milligram per day. The advantages of these medications, they are the cheapest in the whole group, so that is a major advantage, and they are just because of reducing insulin secretion, so the onset and there is quick action, so there is fast onset. What is the disadvantage? the same because of the insulin secretion. There is high risk of hypoglycemia, especially when the patients are elderly or have cognition impairment or not compliant with the glucose monitoring. So regardless of the glucose high or low, they will produce insulin. So there is high risk of hypoglycemia. And then another disadvantage, it causes weight gain because of the insulin production and the cardiovascular risk. And because of the constant insulin production, it leads to the beta cell exhaustion, and eventually the patients will need insulin. So that's a major disadvantage. Next is SGLT2 inhibitor. The expansion of the word is sodium glucose transport inhibitor. The mechanism is increased glucose excretion to the urine by inhibiting renal glucose absorption. So let us look at the mechanism. SGLT2 is a protein that causes the reabsorption of glucose in the proximal convoluted tubule in the kidney. SGLT2 inhibitor, this blocks this protein from reabsorbing the glucose. So what happens? The glucose is excreted through the tubule in the urine, and also the water is also follows. So that is why there is hypovolemia, and we have to be very cautious in elderly. So what are the medications in this group? Empagliflozin, dapagliflozin, another one is there, canagliflozin. So the empagliflozin is another name is, or brand name is Jardiance, and 10 milligram and 25 milligram availability. Dapagliflozin, the brand name is Farxiga. It's available in 5 milligram and 10 milligram. And canagliflozin, the brand name is Invokana. It can be started at the 100 milligram once daily. Even though the name Invokana is popular, be careful and cautious with that. It can cause lower limb amputation risk and the bone fracture, and it doesn't have much cardiovascular benefits like dapagliflozin and empagliflozin. Dapagliflozin is not advised with the patients with active bladder cancer. So what are the advantages of these medications? It decreases the HbA1c, decrease HDL, which is not a good one, but it's not clinically significant when compared to the cardiovascular benefits of this medication. Decrease triglyceride, decrease inflammatory markers, increase ketones, decrease uric acid, and look at here, decrease weight, decrease visceral fat, decrease epicardial fat, decrease systematic infection, and decrease insulin resistance. So these, and also the patients with CKD and EGFR greater than 20 and albuminuria greater than 200 get benefits from this. These medications reduce the CKD progression. There is a decrease in GFR, a slight decrease in GFR once we started these medications, but that is not an indication to discontinue it. So all these contribute to reduce blood pressure, reduce preload, reduce afterload, and decrease total volume. So that helps in the decrease hospitalization related to heart failure and cardiovascular mortality, and it helps with the heart failure with the reduced ejection fraction. So what are the disadvantages of this medication? This is very expensive if there is no insurance, not effective in patients with a EGFR less than 20, and there is a risk of genital infections, genital mycosis, candidiasis, vulvovaginosis, urosepsis, pyelonephritis. So this is why this happens, because there is the glucose is excreted in the urine, and it's contraindicated in patients receiving dialysis, and the because of the risk of dehydrate, the hypovolemia and the loss of water, and the hypotension, this is very not advised in the old elderly patients. Next is a GLP-1 receptor agonist. It acts through GLP-1 pathways. The GLP-1 expansion is glucagon-like peptide. Even though it says glucagon-like, it doesn't act like glucagon. Glucagon, it converts glycogen to glucose, but this doesn't work like glucagon. Instead, it increases the insulin secretion. But how it differs from the sulfonylurea or other insulin secretagogues, because this is glucose dependent secretion. So what that means, it responds to food or increased glucose. If the patient is not eating, there is no insulin secretion, and it slows gastric emptying and promotes satiety. So when the patient is full and they are trying to eat, these medications will make the patient feel nausea. So what are the medications in the group? It's liraglutide, semaglutide, dulaglutide, and there is a whole list on the right side. Let us look into them. And the first one, semaglutide, which is the strongest one. Wegovy is the brand name. The price is 1,349. It's once weekly and it's approved for weight loss. And the semaglutide other brand, Ozempic, $935, and it's once weekly and it's approved for type 2 diabetes. And then ribosus, it's $935 once daily and it's oral. So students, please note, this is the only one available orally in the whole list, and it's type 2 diabetes, approved for type 2 diabetes. So the Wegovy, we can start at 0.25 milligrams sub-Q every week for 4 weeks. So most of these medications, you start at the lowest dose for 4 weeks and then taper based on the patient's weight loss need or the glycemic control. The Ozempic is also available in 2 milligram, 4 milligram, 8 milligram, and you start at 0.25 milligrams sub-Q once weekly and then 4 weeks. And then ribosus is available in 3 milligram, 7 milligram, 40 milligram, and you start at 3 milligram. I know the providers and nurse practitioners have apps that way we can look at the dose and everything. I'm just doing it for the completion of the PowerPoint. And also I believe that by knowing and being thorough about these medications, the providers will be able to start the right medication for the patients. Next one is liraglutide. The brand is Saxenda. The list price is 1,349 and it's once daily and it's approved for weight loss. The same one, they have a brand, another one, Victoza, $744 once daily, and it's approved for type 2 diabetes. So Victoza is available in 6 milligram per ml and you can start at 0.6 milligram. And then Saxenda is available in 6 milligram and you can start at 0.6 milligram daily. Then there is exenatide. The brand is Byetta. It's $940 twice daily and it's approved for diabetes. And Bydureon B-size, $855 once weekly, and it's approved for type 2 diabetes. So this Byetta is 5 microgram and 10 milligram microgram availability. You can start at 5 microgram. Then Bydureon B-size is 2 milligram per injection every week. Then there is Mounjaro or tirzepatide. This is different from other medications. I'll explain in a minute. And their list price is 1,023 once weekly and it's approved for type 2 diabetes. So Mounjaro is different from other group. It's because it's a dual GIP and GLP-1 receptor agonist medication. GIP, the expansion is glucose dependent insulinotropic polypeptide. So this GIP, there is no medication with the GIP alone. They don't cause gastric emptying. They don't reduce glucagon secretion, but they help in the insulin secretion. It amplifies the GLP-1 receptor action. So there is superior glucose control and weight loss. There are another two medications that I want to mention, but it's a little bit about the primary care scope, but still I think we can prescribe for the patients if they are needed. Those patients who are already on insulin but they have complaints of weight gain from the insulin. So those medications, one is Saltafy and then Soliqua. Sultafy is a combination of insulin deglutide plus liraglutide once daily, and you can start with 16 units. Soliqua is a combination of insulin glargine plus lixisenatide once daily. You can start at 15 units. So what are the advantages of this medication? This will prevent the need of increasing the insulin dose, so the insulin dose can be reduced, and then it will help if the patient's getting weight gain from the insulin and the patient is worried about it. So regarding all these medications are parenteral pens. So if you need to educate patients, I have done a video of insulin, so that is included. The pen education is included in the video. Next, let's compare the advantages and the disadvantages of GLP-1 receptor agonists. The advantages are very good. There is a significant A1C reduction, like 1 to 2%. There is significant weight loss. There is lower risk of hypoglycemia, which is good. And there are good cardiovascular benefits, especially with Victoza, Ozempic, and dulaglutide. And it promotes satiety, so that means less hunger, so that helps certain kind of patients. And their disadvantages are that anytime GI system is involved, there is nausea and vomiting and diarrhea. And then there is these medications are mostly injectable, and they are expensive, especially if you don't have insurance or the insurance don't cover. And then we have to titrate the dose. And then it is contraindicated in patients with a history of thyroid medullary cancer, so and also risk of pancreatitis. Next is DPP4 inhibitors. The expansion is dipeptidyl peptidase 4 inhibitors. The mechanism is it prevent degradation of GLP-1, increasing insulin secretion. So if you understand the previous slide, I explained the GLP-1. This would be easier for you. So when the patient eats food, it goes to the GI tract, then there is incretin hormone action, the secretion of active GLP-1 and GIP will make the beta cells produce insulin, where GLP-1 alone will cause alpha cells to suppress the glucagon, and then there is suppressed glucose production, so there is a glucose decrease. So this is how incretin hormones act, or GLP-1 receptor agonist act. In the case of DPP4, there is a DPP4 enzyme which causes the active GLP-1 to inactive. So DPP4 inhibitor function is to suppress this action of this enzyme, which causes a GLP-1 to inactive. And also it helps the GLP-1 to continue the action. So the medications examples are sitagliptin and linagliptin and saxagliptin. Sitagliptin, the medications available are 25 milligram, 50 milligram, 100 milligram. Linagliptin, the medication available is 5 milligram, and the brand name is Tragenda. And sitagliptin, the brand name is Januvia. And saxagliptin, there is no brand name. It's available in 2.5 milligram to 5 milligram. Even though these medication names are popular, there are side effects of nasopharyngitis, UTI, upper respiratory infection, diarrhea. And who are the group of the patients who will benefit from this medication? Suppose there are patients with the problem of hypoglycemia when they are on oral medications, but they are not continuously monitoring these blood sugar level, like elderly patient, those who have cognition problem, and they don't need, who are needed not much cardiovascular benefits, and also those who should be on GLP-1 receptor agonists but they cannot afford it. So another advantage of this medication is that they can be orally administered, no injection. And regarding weight gain, there is no weight gain, it's neutral. And I already explained it's well tolerated and safe in elderly, and once daily dose is available. And the lowering A1C is 0.5 to 0.8%. Regarding the cost, it's $234 to $568 for a 30-day supply. Other than the side effects that I mentioned, there are serious angioedema kind of reactions or anaphylaxis as reported, and there is a rare risk of pancreatitis or severe joint pain, and they are not recommended with GLP-1 receptors. And there is limited cardiovascular outcome benefits with these medications, and except linagliptin, all the other medications, there is a you need a dose adjustment for patients with a chronic kidney disease. Next group of medications is thiazolidinedions. I put it in a risky group because it can potentiate the heart failure. So we don't, as prescribers, we don't want to miss that. And they belong to the class of insulin sensitizers, which is the same class as biguanides, metformin. So they increase the insulin sensitivity. So there is less chance of hypoglycemia, which is the advantage of it. And also they promote differentiation of the adipocytes or fat cells, so there is increased uptake of the fatty acids, and also there is in the muscles, and also there is in the peripheral tissues there is increased glucose uptake. But the disadvantage is that these gamma receptors located in the distal nephron, they act like aldosterone. So if any medical student is watching, they can remember with thiazolidinediones, so that increases the sodium and water resorption, so that can potentiate the heart failure, and that can also cause weight gain. So that is why this medication should be contraindicated in patients with a class 3 or 4 CHF, or patients with symptomatic CHF, and also is contraindicated in moderate or severe hepatic impairment. And there is a fracture risk more in postmenopausal women, especially when if the patient is on proton pump inhibitors or taking corticosteroids. And what are the class medications involved in this group? It's pioglitazone and rosiglitazone. Both have the same side effects, and also there is increased risk of bladder cancer for pioglitazone. The brand name is Actos. It is available in 15, 30 and 45 milligram. You can start with the 15 to 30 milligram. Rosiglitazone is only available in generic form. So far we have discussed diabetes, pathophysiology, different classes of medications, their doses, their side effects. Next is about how to start treatment. Mm, so if the patient is newly diagnosed as diabetic and their HbA1c is not very high, they want to try lifestyle management, we can recheck the A1c in 3 months. So they will go to physical activity, weight management, diabetes self-management education, nutritional counseling. So if still the HbA1c per American Diabetic Association not less than 7%, we should start on metformin and plus lifestyle changes. If still the target is not achieved in 3 months, then we will go to look at the patient's different condition to add to the second medication. So that is atherosclerotic cardiovascular disease, the GLP-1RA or SGLT2 inhibitor. They have major cardiovascular benefits. Then heart failure, SGLT2 inhibitor. I already explained how is the mechanism. Then chronic kidney disease, SGLT2 inhibitor and GLP-1 arrays reduces the progression of the kidney disease. Then there is need for weight loss. Avoid sulfonylureas and glinates because they cause weight gain. These GLP-1 array and SGLT2, because of their mechanism, they helps in the weight loss. Then high risk of hypoglycemia. Also, they avoid the sulfonylureas and insulin. Why? They secrete the insulin. Then which are safer, DPP4 inhibitor, GLP-1 RA and SGLT2 inhibitor, and thiazolidinediones. Cause concern, again, as GLP-1, SGLT2 are expensive. Use this one, sulfonylureas and TCDs, which are cheaper. Look at the cost for awareness. Biguanides $10 to $13. They are the most preferred group because they are affordable and no hypoglycemia. Then sulfonylureas $12 to 18. They are cheaper, but there is risk of hypoglycemia. Thiazolidinediones, it's a generic, it's cheaper. And then DPP4 inhibitors, it's expensive, 234 to 568. Their mechanism mechanism is good. Then SGL2 inhibitor, it's 354 to 627, very expensive, but they have heart failure helping mechanism. Then ASCVD, CKD, all these are very good drug in those conditions. Then the others one we are rarely use. So that is a summary of how we can use the medications in different conditions. Next, we are going to talk about how the diabetic medications act on lipids and also help in heart failure. So the first table is about different medications. So metformin, GLP-1RA, SGLT2 inhibitor, insulin, all helps in the decrease in triglycerides. So if we get a patient with increased triglycerides, so we can decide which medication we have to choose. Sulfonylureas, DPP4 inhibitor, they are neutral. TCDS helps in increase HDL, which is a good thing. Now we look at the heart failure. So you can see there are 7 medications. Out of this, only 3 will help in reducing the risk of CV events, which is, you can remember by MSG, metformin, SGLT2I, and GLP-1RA. Out of this, SGLT2 only helps in the heart failure, which is closer here. So the sulfonylureas and DPP4 is neutral regarding cardiovascular events and the heart failure. The insulin and thiazolidinedione, insulin can cause increased risk of heart failure, and thiazolidinediones we already discussed, there is increased risk of heart failure. Next is regarding comparison of A1C reduction of different medications. Why this table is important? Because a patient comes to you, their situation will be different. They may have ASCVD, they want weight loss, their cholesterol is high, so they may need A1C reduction. All the other things are normal. So we have to use prescribed medications based on what is the situation of the patient. So Biguanides, the A1C reduction is 1 to 2%. So that is a major reduction. So it is affordable, and also you can reduce the A1C reduction 1 to 2%, while SGL2 inhibitor, they have major cardiovascular help, but the A1C reduction is only 0.5 to 1%. Then sulfonylureas 1 to 2%. There is another one missing here is a GLP-1 receptor agonist. Their A1C reduction is also 1 to 2%. Meglitinides, which rarely used, which 0.5 to 1.5. TCDS, see 0.5 to 1.5, very good. And then DPP4 inhibitors 0.5 to 0.8. The other two are not much used, so not talking. So the A1C, knowing how much the A1C reduction of different medication is very important in prescribing the medication. Before we discuss about follow-up after treatment, as providers or nurse practitioners, we should be able to educate patients regarding diet, exercise, and therapeutic lifestyle changes. You can view my video on dyslipidemia. I'm talking about education regarding diet and exercise in that video. In this video, I'm not talking about any diabetic diet education or any other education, because the goal of my video is to make nurse practitioners expert in prescribing the oral anti-diabetic medications. So as a summary of this video, even though we have all discussed all the medications, their side effects, and each class of medication, what are the contraindications and what we should be careful, to summarize, just for us to remember, just about all class of medication. Metformin we should avoid in patients with the GFR less than 30. We should avoid in patients with the liver failure or heart failure, so we can avoid lactic acidosis. And then DPP4 inhibitors we should avoid in patients with a history of pancreatitis and then heart failure. Then regarding sulfonylureas, we should avoid in patients who has no compliance in regularly checking the blood sugar or or regular meals, and then when there is renal or hepatic impairment, or in elderly patients. Then SGLT2 inhibitor, we should avoid the patients who has a GFR less than 30, and also patients with recurrent UTI or infections or urosepsis or pyelonephritis, and when the patients have low blood pressure. Next is Thiazolidinedions. We should avoid the patients with a heart failure, because this medication itself can cause heart failure, and avoid patients with osteoporosis, bladder cancer, and liver disease. And then regarding GLP-1 receptor agonist, we should avoid in patients with medullary thyroid cancer. Hey, I hope this video was very helpful. We covered a lot of content. This will help in your nurse practitioner career in becoming experts in prescribing oral anti-diabetic medications. Thank you for listening to me. Next, I'm sure you have all the answers right. Which class of diabetic medication is not a choice if the patient has hypoglycemic risk? The answer is A, sulfonylureas. Next question, which medication has high risk for lower limb amputation? The answer is A, canagliflozin. Third question, which class of medication should be avoided in medullary thyroid cancer? The answer is D, GLP-1RA or GLP-1 receptor agonist. Thank you again.